The risk of peri-implant disease differs among patients, but this diagram makes it easy to identify the risk based on 8 key factors. Just remembering this one diagram will be sufficient. By simply entering the information on the right side, you can determine each patient's risk level for peri-implant disease. I am Song Young Gyun from the Department of Prosthodontics, College of Dentistry, Dongguk University. In today's Journal Inside, I'd like to introduce a practical paper that can be applied in clinical practice. This journal introduces a study on implant disease risk assessment. The risk of peri-implant disease varies among patients, and this paper presents a method to intuitively visualize each patient's risk level using numerical values and a diagram. Furthermore, within the 8 factors established in this paper, it provides a simple way to identify the level of risk, making it a practical study that is helpful in clinical practice. This is the Implant Disease Risk Assessment functional diagram. According to this journal, it's recommended to remember just this one diagram. In this paper, the 8 factors influencing peri-implant disease are as follows. Let us take a look at each factor one by one. The first factor is a history of periodontitis. The level of risk is determined by whether the cause of tooth loss prior to implant placement was periodontal in origin, or whether it was due to other reasons such as caries or trauma. The second factor is BOP. Bleeding on probing is considered a relatively objective indicator of inflammation. Several studies have demonstrated that a BOP percentage of 20 to 30% increases the risk of progression of periodontal disease. Bleeding on probing at implant sites has also been reported in studies to be closely associated with disease progression. Therefore, in this paper, 25% was set as the threshold for high risk. Based on a binary classification, the maximum cutoff value was set at 49%. The third factor is probing depth. The presence of deep periodontal pockets indicates a very high likelihood of periodontal disease. In particular, many studies have reported that periodontal pathogens are likely to be present in periodontal pockets deeper than 5 millimeters. In this paper, patients with 6 or more sites presenting periodontal pockets of 5 millimeters or greater were considered to be at high risk for biological complications. The maximum cutoff value was set at 10 sites. The fourth factor is the degree of alveolar bone loss in relation to the patient's age. The estimate of alveolar bone loss is determined based on the site showing the most severe bone loss caused by periodontitis. With bite-wing radiographs, the degree of bone loss is calculated as a percentage, based on the site with the greatest loss. Therefore, it is acceptable to consider 1 millimeter of bone loss as equivalent to 10%. For example, in a 40-year-old patient whose site with the greatest alveolar bone loss shows 2 millimeters, this is regarded as 20% loss, and the bone loss relative to age can be calculated as 0.5. In this paper, 0.5 was regarded as the threshold distinguishing between low and moderate risk, as well as the cutoff value for high risk. The next factor is periodontitis susceptibility. Susceptibility to periodontitis is determined according to the classification of periodontal and peri-implant diseases proposed by Tonetti. In this context, an understanding of staging and grading is required. Tonetti classified staging into 4 levels and grading into 3 levels. Staging is an assessment that focuses on the present condition or extent of the current disease. Grading is an assessment that focuses on the rate of disease progression and prognosis. Staging is evaluated based on clinical attachment loss, radiographic assessment of alveolar bone loss, tooth loss due to periodontitis, and maximum periodontal pocket depth. Grading is determined by the rate of disease progression as well as the presence or absence of factors such as smoking and diabetes. The classification of susceptibility to periodontitis is primarily based on staging, and patients with grading of C or higher are categorized as a high-risk group. As is the case with most assessment indices, even if only one of the evaluated parameters meets the most severe criteria, the overall grade is elevated accordingly. Regular checkups and maintenance also play an important role in risk assessment. In particular, several studies recommend a recall interval of 5 months or less. When patients fully comply with the regular checkup schedule recommended by their clinician, the risk is reduced, whereas failure to keep the recommended schedule results in a higher risk. The distance from the restorative margin of the implant prosthesis to the marginal bone also serves as a parameter for predicting the risk of peri-implant disease. In this respect, tissue-level implants have an advantage over bone-level implants. The risk increases when the distance from the prosthetic margin to the marginal bone is less than 1.5 millimeters, and this is also related to the design of the abutment. This is because when the abutment diameter is the same, the emergence angle is determined by its height. Finally, the eighth factor is related to the implant prosthesis. In peri-implant disease caused by implant prostheses, an important factor is whether adequate oral hygiene maintenance is possible. Oral hygiene maintenance varies depending not only on the dentist but also on the patient's oral hygiene practice. Therefore, the dentist should evaluate oral hygiene based on the patient's oral hygiene status rather than the prosthesis itself. In addition, iatrogenic factors such as marginal misfit or the presence of residual cement are also included. So, if you ask whether all of this needs to be assessed manually, the answer is no. A website, perio-tools.com, already provides assessment resources related to periodontology. In this website, by entering the reference values, the system automatically performs the evaluation. When you access the website, select the IDRA chart among the various charts. And by entering the information on the right side, you can assess the patient's risk of peri-implant disease. Now, let us go through a practical example. In this chart, you first enter the patient's name and date at the top. Then, you proceed to the items on the right-hand side. First, you enter the patient's age, and then the number of remaining teeth. Next, enter the number of probing sites per tooth. Then, input the number of implants, the number of probing sites per implant, and the number of BOP-positive sites. Then, you select whether or not the patient has a history of periodontitis. In terms of periodontal susceptibility, since this patient has lost teeth due to periodontitis, the classification is stage 3. However, as the patient is neither a smoker nor diabetic, the grade is A. Next, you enter the number of sites with a pocket depth of 5 mm or greater, as well as the percentage of bone loss. You also record whether the recall interval is being properly followed. Based on this information, the patient in this case was classified as moderate risk, and you can check the items that need attention in the diagram. Pocket depths of 5 mm or greater can be managed through periodontal treatment. Management for this case is more important than others. However, if the input conditions in this patient's profile are changed, the overall risk rating will also change. Therefore, without having to calculate everything directly, entering just the numerical values allows the results to be intuitively displayed in the form of a diagram. By using this website and showing the results to the patient, it can also serve as an effective tool for explanation. The significance of this paper lies in the fact that it provides an intuitive assessment of the risk of peri-implant disease, which helps clinicians establish management plans in clinical practice, and also assists patients in understanding their current condition. In other words, it can be considered a clinically friendly study. I hope you find this website useful in your clinical practice, and that today's paper has offered you new insights. With that, I would like to conclude my presentation. Thank you.